I know no point preaching to the converted because you're all experts in the crowd, but share with you some lessons that I've learned over the years and share you some philosophy. I represent Singapore and the Asia Pacific Ophthalmic Trauma Society, and this is a society which has maximum numbers from India and Indonesia, where we practically have those interested in ophthalmic trauma of interest worldwide members, over 450 members, and that's where Fracture Scanner comes in. I'm happy Dubai periodically celebrates various things as well. This is the Diwali light up over there. And right now we're doing a campaign against fireworks-related globe injuries, which is again a big cultural topic in India and Southeast Asia. These are my conflicts of interest, but based on the books that we published in the past, but no real conflict itself. First, the other day we talked about the difference between ocular and ophthalmic trauma. The difference between the two is that when you have adnexal injuries, for every single real globe injury, you have adnexal injuries. That's where the orbital fractures come in. We went up to talk about it as an orbitofacial fractures because only 30% of them are pure orbital fractures. Rest of them are real orbitofacial fractures. I'm going to touch upon the practical classification and finally the patient-specific modifiers. This is an example of a patient where there's both a globe injury and a foreign body in the orbit. So it's not just a pure globe injury, but it's an adnexal injury as well. And the globe injuries can be classified as so, including globe avulsions, which is not typically included. And full tribute to Ferenc Kohn, who actually described the Birmingham eye trauma terminology, but we are adding in the literature globe avulsions as well. But when it comes to orbital trauma, there can be pure contusions, which is purely soft tissue, or fractures itself. And the thing about the practical classification is we've designed it for us ophthalmologists and oculoplastic surgeons, which completely overcomes the challenges with the standard classification the craniomaxillofacial surgeons use. And we incorporated that into a complete assessment into this scale, which is published in Indian Journal of Ophthalmology. So if you look at the two scans over here, yes, both of them are orbital fractures, but what's the difference? One is purely inside the orbit, one involves other cavities including intracranial cavity and the midfacial region as well. That's the difference between a pure orbital fracture and an orbitofacial fracture. So we assimilated that into a simple, pure internal orbital fracture that we ophthalmologists can easily manage by ourselves, versus the complex fractures including a ZMC, which involves the lateral wall of the orbit, which involves the floor of the orbit, but also involves the rest of the facial skeleton. So that's a practical classification we come up with as linear fractures, blowout fractures, one wall, two wall, three wall fractures, or blow-in fractures, which have to be managed differently compared to the other complex fractures, including cranio-orbital fractures, where you need a neurosurgeon involved, and then a panfacial fracture, including the mandible, which has to be fixed all together in one go, underscoring the value of an orbital surgeon in a panfacial trauma team itself. So these are examples of pure internal fractures where one or more walls are involved. Rest of the facial skeleton is intact, the rim is by default is intact, and we make the decision regarding threshold for intervention, timing of intervention, approach to intervention, what implants, keeping the basic principles of live globe vision impact. As opposed to the complex fractures where it goes beyond the orbit, into the zygoma, into the ethmoidal cavity, into the skull base. Remember, orbital roof is a skull base structure. Likewise, the floor of the orbit involves a maxilla and the rest of the facial skeleton, which has to be co-managed with an orbitofacial surgeon or craniomaxillofacial surgeon. And these are examples of complex fractures where if you get your concepts right, in a single stage approach, you're able to put the roof, the lateral wall, inferior orbital rim, and then and only then you do an internal reconstruction. You get that kind of anatomically correct reconstruction in one go, without having to mess around with repeat revision surgeries. More examples of complex fractures where I have neurosurgeons, orbital surgeons, ophthalmologists, and a craniomaxillofacial has to be involved, where you use various approaches. The next 2-3 minutes I'm going to talk about the patient-specific modifiers. This is what helps you decide when you're going to fix it, how you're going to fix it. And we put it in the A, B, C, D, F, G, H, I categories where based on age, based on bilaterality, the complexity of the fracture, whether there's true tissue entrapment or not. Remember, it's a clinical sign, not a radiological sign. Whether there's associated foreign bodies within the orbit. Are you going to take it out first time, later on? Whether there's underlying globe injuries or optic nerve injuries that can delay orbital fracture intervention. Whether it's a high-risk patient or a low-risk patient. Am I going to intervene in this patient or not? And finally, the I stands for whether you're going to intervene or not. And that's what the patient-specific modifiers kind of comes in. And we have 2 minutes and I'll try to run through it. For example, age makes a huge difference. The younger the child, more displays the fracture, the entrapment, the earlier you go in. Likewise, there's bilateral unilateral fracture. You got bilateral symmetrical deformities. There's lesser threshold for intervention or higher threshold for intervention versus if a unilateral deformity, you have a lower threshold for intervention. Likewise, when you talk about complexity, we talked about whether you're going to be as a multi-specialty or uni-specialty approach. The degree of displacement, milder the displacement without entrapment, you don't need to fix it. The larger the displacement and more the entrapment, you end up fixing it, and E becomes an entrapment. Remember, it's a clinical sign that you elicit, not a radiological sign, as you can see in this chart. The younger the patient, the earlier you go in as well. F stands for the presence of foreign bodies, either the globe or within the orbit. That tells you whether you're going to remove the foreign body at the same time. G determines whether there's an underlying globe or optic nerve injury. Hence, do not disregard the vital structure inside the orbit. H stands for whether the patient is a high risk factor on blood thinners, multiple comorbidities versus a young adult patient, where you don't want to sit on these patients, intervene much earlier. And finally, the decision about whether you're going to intervene or not, whether you're going to intervene by yourself or with somebody else, whether you're going to intervene within the first 24, 48, 72 hours, 2 weeks, or much later on as well. So in summary, the practical classification is a very practical guide for ophthalmologists, residents, fellows, consultants, and to talk the same language with non-ophthalmologists and try to incorporate it. We have now incorporated that as a standard of communication with various trauma societies, and we are putting together a global trauma consortium as well. So I'd like to put a pitch in the next 10-15 seconds for the next Orbit Oncology and Thyroid Eye Disease Symposium we are organizing in October next year. Invite you all. It's going to be the first UGOGO meeting. We remember UGOGO outside of Europe itself. And finally, invite you to the APOTS meeting, which is going to be at the top of the world in Kathmandu in November next year. Thank you very much.
Thank you. Thank you. Thank you, Dr. Sundar. Actually, I had listened to this lecture in Prague 2 months back, and it was 20 minutes. I don't know how you did it in 7 minutes. It's very good for you.
Now, respect for you and the audience, sir.
Yes, we can there is a place for 2 or 3 questions. We can discuss the first 2. If anybody would like to throw a question. For example, I want to ask you how frequent you would say on ocular injury with orbital fractures. It's very rare in my
So I always ask this of medical students, which is a stronger structure? Is it the globe or the orbit? People think the globe soft tissue structure is a very weak structure. Actually, the orbit is a much weaker structure than the orbit, because we see 8 to 10 times more orbital fractures than open globe injuries. The proportion of significant globe injuries, there's insignificant and significant. Mild contusions are very common. Significant globe injuries is less than 10-15%. So that's the proportion we used to have. But you don't want to be working in a center where they're only fixing fractures, ignoring the globe. That's why every one of us as ophthalmologists working various setups become an integral part of a facial-maxillary trauma team.
Of course, you attend to the ocular injury first and then the orbital.
Absolutely. And we tell the maxillofacial surgeon, delay the fracture repair, let's stabilize the globe versus let's fix the globe and you can fix it later versus you can go in at the same time.
Ganga, can I ask you, in blowout fracture or orbital floor fracture, I think you have many experience with the absorbable orbital implant. What is the advantages and disadvantages between that?
Yeah, so again, we created the concept of neo-osteogenesis, which means that when you follow these orbital fractures over time, bone heals. Sometimes in the wrong position, sometimes the right position. So that told us that now about 40 to 60% of the fracture implants we put in both adults and almost all children, they are bioresorbable implants. You do not need a permanent scaffold against the medial wall or the floor or the lateral wall. So only the patients who are likely to be injured again and again, motorcyclists, those involved in boxing and contact sports, construction workers who have multiple wall complex fractures, we put permanent implants. By default, all other patients do get a bioresorbable implant. And it absorbs over 12 to 18 months, by which time the bone heals and you don't have to deal with the complications of a permanent implant.
Did you always performing to reconstruct the medial wall, or did you only selected cases in the medial wall? Because I think not all the medial wall fracture we can perform the reconstruction.
Absolutely right. I mean, you do not have a significant enophthalmos. Remember, 2 millimeters is physiological. It becomes clinically significant 3 millimeters onwards. So when you do not see an acute proptosis and an acute trauma with a large defect, these patients are going to get developing enophthalmos. We would intervene. But even if you have a large fracture, sometimes you don't have much of a clinical enophthalmos and there's no entrapment, no limitation of issues, no diplopia. You don't have to necessarily treat these patients.
Fine.
Thank you.
Fine. Thank you. Can I ask? Thank you. Very good. Dr. Muhammad Amir, about you said CT or MRI, whatever is your preference to assist the patient with thyroid eye disease?
I was a bit short on that because you need a CT scan to outline the bony orbit, and you need to know where you want to remove the bone for maximum effect. The MRI is important because in acute stages, sometimes you see that the muscles are not very enlarged, and the extracellular matrix or the fat and the orbital tissues are enlarged more than the muscles. So in those cases, in those patients, they're usually younger patients, and you might need to remove the fat more to get a good effect for decompression. And so that's why MRI is also very important in these
Fine.
patients. So I tend to do both before we plan the surgery.
Yes, if you can. Any question? Okay, I think we proceed. Thank you. We proceed with Dr. Ihab Saad Othman. Dr.